Dr. Klinge. Hi, you remember a surgery last December that Dr. Sullivan did, and you had to come in the middle of the surgery and help her find
Oh
the.
yeah.
That was me.
Oh, it was you. Never got to meet you.
I never got to
Yeah.
meet you. I'm like, you did part of my surgery, and I never met you
Yeah, it
before.
was tough because I guess she
Mm.
explained to you it was, of course, very tight, and so it kind of,
Yeah, she said it was buried underneath a lot of nerves and
yeah,
stuff like that.
sometimes it happens, because
Yeah.
it's a matter of chance, where it hides.
Yeah.
Often it pops up, but it can also be the other way, it kind of
Oh,
it's pulled to the front.
yeah. She
And of
said you
course,
hadn't seen a lot of like that before.
yeah, so, we had to find it, but we
Yeah.
found it.
How many have
Um,
you seen like how many of those you've
Yeah, we
seen
see
like
it
that?
like I have to say we see it more, and so it's not so unusual for me because I do like little kids as well. We
Mm.
see it more in little kids. Uh, and I don't, always thought it might be like also the anatomy in the kids,
Mm.
and kids naturally have a little bit more like fuller spinal canal.
Mm.
So I thought it might be, so then, but then I learned, sometimes, and we have now like maybe a handful of adults,
Mm-hmm.
older adults, where it's the same thing, we have to kind of fish for it.
Yeah.
A little bit, yeah.
That's
But I
interesting.
usually see it in little kids, like
So what it was in a different spot than
no, it was
usual?
still where but it was deep,
Oh,
So when
deep.
you open the dura, you
Mm-hmm.
usually see that phylum.
Uh-huh.
It's kind of like the nerves are more
Mm-hmm.
down, the
Mm-hmm.
phylum is up. And you usually have to just kind of do a little bit of a move of the nerve, and then you
Mm-hmm.
find it there.
Mm-hmm.
But yours was
Mm-hmm.
way in the
Oh.
canal, and it must have been because it was like, first of all, it was very tight,
Mm-hmm.
and because sometimes it's also the way how people. So if it's super tight
Mm-hmm.
and how we position people, it
Mm-hmm.
might just then be bent forward,
Oh.
But we need that position
Mm-hmm.
that we put like the people like a
Mm-hmm.
little bit on a bend.
Mm-hmm. Mm-hmm.
You'll bend it,
Yeah,
like
yeah.
this. And
Yeah.
so it must have just, your phylum was just so tight that it kind
Wow.
of snapped
Wow.
but it was still there where a phylum is
Yeah.
supposed to be,
Yeah.
but it was just
She
hard to
said it was
find.
like the worst one she's ever seen at the
Yeah,
time.
yeah. And I
I'm
was
like,
in
oh
another
my
room, and
God.
thanks
Yeah.
God I was just kind of like finishing up,
Yeah.
So
Thank
that was
God.
you.
That was me.
Oh, hope you're doing all right.
Yeah. Yeah, I'm doing well. My
Yeah.
neck is a lot better,
Mm-hmm.
so I'm very happy
Oh,
about
that's
that.
right.
Yeah.
Was it one of the first things that you noticed?
Remember that in my chest was very, very tight, and
Mm-hmm.
that went away immediately. That was
Mm-hmm.
went away. I
Mm-hmm.
still have like some stiffness in my back,
Mm.
but I have more feeling in my legs now.
Oh,
So I'm
that's
doing
good.
pelvic floor PT, so slowly that's getting
Yeah.
better. Thing.
Also a little bit
So
more strength in the legs, would you think?
I'd say more strength and more
Yeah.
feeling. Like I have a lot of, I wouldn't say weakness, but like sensation. Well, actually
Mm.
in my hip.
Mm.
And then I also had an internal hemangioma in my left
Mhm.
knees.
All right, welcome everybody. Thank you so much for coming today and welcoming Dr. Klinge to come speak with us. I want to give a little bit of background on Dr. Klinge if you're not familiar with her work. She's a professor at the Brown University Medical School, as well as a neurosurgeon at the Rhode Island Hospital campus. She's known internationally for her work on hydrocephalus, cerebrospinal fluid disorders, and complex brain and spine conditions like tethered cord. She earned her medical degree magna cum laude from Christian Albrechts University in Kiel in Germany, where she first became fascinated with how the brain's fluid systems impact health and disease. She went on to complete her neurosurgery training at Hanover Medical School, also in Germany, which earned her habilitation, which is the right to be a professor, which is the highest achievement you can get in Germany. After she built that very impressive career in Germany, she came over to Rhode Island to join Brown University and Rhode Island Hospital in 2009. Since then, she's led the Center for CSF Disorders of the Brain and Spine, combining research, innovation, and patient care to help understand conditions like normal pressure hydrocephalus, Chiari malformation, and tethered cord. Her research has shed a light on how CSF fluid flow affects brain function, aging, and recovery. She's published widely, and she serves as editor-in-chief of Interdisciplinary Neurosurgery, which is a scientific journal, and previously led the International Society for Hydrocephalus and CSF Disorders. Beyond her research and surgical expertise, Dr. Klinge is really well known for her compassion and kindness, her dedication to patients with rare and complex neurological conditions, and she's also been an excellent mentor in helping to train other physicians on how to treat some of these really complex conditions. In researching some of these conditions, it's state of the art, and she's been taking a risk for our community to be able to research these. So I'd like to give her a very big thank you and a round of applause and welcome Dr. Klinge. Oops. You try to talk now?
Oh, yeah.
Be too loud. How about that?
How does that sound? Good.
Better?
Nope. I can also speak loud. People say
Try again.
hello, hello. Oh,
Okay,
good.
we'll go with that.
Okay. All right. Well, I'm very excited, and it's great to be here. So many familiar faces. I feel like I'm coming back to see family. That's how it feels. So we had a couple of meetings, but that was before the pandemic. And I guess everyone feels the same. The pandemic has like taken away like a few years of all our lives. But we keep going, we keep moving. So I'd like to be mindful of the time, but I heard we have a lot of time because we have to catch up about a few things. And certainly, as much as I also going to talk about treatment and our recent data on, outcome and also some complications in tethered cord, I have to talk about research. And I just want to mention one thing. I'm so happy that I have members of our research department here, Amanda, May, and Maria, right? Ilza. So they, joining me today, and we have to also thank them for making a lot of research that we're doing happen. Thanks for coming. So let me see how that works. So first, research. So when I, as a first year resident, one thing that stayed with me was when I went into academic neurosurgery at Hanover Medical School, one of the attendings said, Petra, one thing you should know, you either publish or you perish. And I said, oh boy, how am I going to do this? So at the very beginning of my residency, I started to read other articles and journals because I knew this is going to be the lifesaver, kind of. But my mentors also said, like whatever you do in your life, if you don't publish it, it doesn't exist. So that's how I always, like was anxious to publish the work. And this is like, since we had the last meeting, I was kind of looking up what did we do? Well, yeah, we published. Maybe during the pandemic, we just had time to sit in front of our computers and write stuff. But of course, also we made advances, and certainly also thanks to all of you. That goes without saying. You are part of this history and the story, and also you will be part of the future. So our research was also always very focused on, what is it with the telecord? As you know, the telecord is occult, and it's probably more occult than we ever thought it is. And when you talk to other neurosurgeons or neuroradiologists, they say, well, if the spinal cord is not pulled down, that can't be tethered cord. So I was thinking, okay, well, I have to prove, how can you still have tethered cord if the spinal cord is not pulled down? That's why I'm showing this picture here. Normally it would terminate at L1. I have to tell you this, but there is like a variation, and I learned that in occult tethered cord, sometimes you're a little bit on the upper curve or upper, lower area of the bell-shaped curve at L2 or maybe at L3, but sometimes it's totally normal and occult. So before I update you about like our most recent and new research endeavors, hot off the press, I will just like to summarize what we already published. And I saw that you had some reprints. Our department chair, Dr. Gokastan, was very generous. He always, gave me the money for open access. Because I went to him and said, hey, we have to have open access because, like everyone needs to read it. And so he supported that, because open access these days, if you want to have, it's like $3,000, or $4,000 you have to pay for having open access. So it's some money. So this was a seminal paper where we did show, the mechanisms of occult tethered cord syndrome and hypermobile folks. And the mechanism, we could prove, and this is the take-home message, is that even though the phylum is at normal length and it's all occult, it is failing elastically. It cannot buffer stress and strain anymore, or any impacts to the spine, and that is in fact due to collagen damage. So that wasn't really my idea. So when I went to Ehlers Danlos national meeting in Canada, in Toronto, there was this geneticist, and he did some ultra-structural studies in the skin in hypermobile patients, and he showed all this disheveled collagen, and I said, gee, the phylum has also collagen. So let me look into the collagen of the phylum. So that's where I got the idea. And then, as you know, we published this picture where we found in the phylum that in a non-EDS phylum, let me say it that way, up here, you can see my little, you see like this well-aligned collagen with the D-bands, which is the structured collagen. But then, in EDS, but also in some non-EDS phyla, we saw like a swelling of the fibrils here, and then like swelling here as well. You see the fibrils, and then they actually, they're called, ironically, they're called zebra-like collagen. I'm serious. I'm serious. I couldn't believe it when I read it. I said, well, there we go. Terminology you knew it all along. So this change here is not EDS type. This corkscrew collagen we also found in non-EDS phylums. This is more like a sign of mechanical overuse found in, for example, muscle tendons. And that's how we made the analogy that maybe the phylum is our spinal cord tendon and it's mechanically overstretched. And then why you find the same corkscrew deformity like you find it in, like in the phylums of hypermobile people. So it is a mechanically overused structure. But then, and we will get back to that later, we also found inflammation in the phylum. You see here the specimen of the phylum. You see here like we found the mast cells, which you all know, and I have to say something about that at the end. But we also found lymphocytes and macrophages. And the thing is, like the lymphocytes, are in the blood, right? So you would think, how can, like something from the blood get into the phylum? Of course, if you're an embryo, all layers are kind of glued together. You could always say that, cells mix up. But it was a little bit of a surprise that we find peripheral, blood cells in the phylum. At the time, back then, our conclusion was, okay, it's an inflamed phylum, probably from mechanical overuse, and that makes sense because now we're saying the phylum is actually like a muscle tendon, right? And so why should it not be inflamed? At the end, I'm going to give you another explanation of that. Surprise. So there always has to be a little surprise. So this is like a lot of biodynamics, but I spent like weekends to understand that one curve. So don't think I'm not that smart. So I tried to understand the dynamics of a muscle tendon, and so real quick, I want to share this with you. So when you, oops, sorry about that. When you lengthen the muscle tendon stays elastic for some time. It kind of buffers that that strain. But if you lengthen a muscle tendon by more than 8%, it ruptures because the collagen breaks. So that's the classical profile of a muscle tendon. So now watch this. This is from Philippe Deflo, a Belgian neurosurgeon. He did the same thing with with a phylum of a cadaver human, and you can see here. Look at this. The linear is linear. Line here is meaning elasticity is preserved. It's a good elastic, ligament. But again, phylum at 8% length change, it breaks, and goes out of whack, pretty much like a tendon. So we really could show that the phylum is like a tendon. But then look at people with HEDS. So our classical tethered cord patients, when we use their phylum and stretched it in the lab, Vikas Srivastava is a biomechanics researcher at I don't know whether you know him, at the Brown University Biomechanics Lab. He stretched the phylums that we took out in surgery, and we could show that in non-EDS phylums, they really behave like a tendon, as you can see here. But in EDS, it's still like a little linear tendon-like curve, but already at 4% of stress of elongation, the phylum breaks. So there is basically less stress resilience. So that is a big difference. And so basically what it's got to be that the stress is no longer buffered. So it's basically a bad shock absorber. Our phylum is supposed to absorb shocks, but with the abnormal collagen, it doesn't do it. So basically, if you have a broken shock absorber in your car, you have a bumpy ride, right? And that's what it is. So why is it important? Before I give you now something very exciting, what we're doing is, so of course this is all biodynamics, right? But why is it important? It's important for two reasons. So basically, it doesn't matter whether you have a tight phylum or a too loose phylum. Any, abnormal suspension of your spinal cord in the spinal canal can be devastating. And you can only understand that it's some more engineering. Actually, that was the idea of my husband, Thomas. So shout out to Thomas. He was kind of trying to make sense out of it, also on weekends. So he said, okay, basically it's all like a spring mass damper system, The mass is the spinal cord, the phylum is the spring. Our spinal fluid system, where everything is soaked in, is our damper. Okay, so if you have a bad spring, a bad phylum, it can be too tight, it can be too loose, it's shaking around the mass and also maybe affecting the damping system, the spinal fluid system. So this is all like one system. So we have to think of spinal cord, phylum, anchoring of the spine, spinal fluid as one system, and these are the systems that we are trying to understand now. This would get us to the next steps, but now we understand what's happening. And basically, the tethered cord situation has helped us to give this spinal dynamics a totally new understanding. And now even my spine colleagues are now fascinated by this. If I had spoken to them about tethered cord like 15 years ago, I said, "Oh yeah, let's better go to the bar and have a beer, but we're not going to talk about tethered cord." But now it's different. They understand that we're dealing here with something really novel. So what I'd like to say now, that gets me to the next part of the talk, which is kind of exciting, is like what it really means, and that was helping me so much to, not that I believed everything from the get-go, but that made me even more of a believer. If you have a bad shock absorber and you have abnormal motion and anchoring of the spine with tether cord, then you believe, all these unheard symptoms that are not in the textbooks. This is a picture a patient gave me. She was admitted actually to the hospital, and she needed somewhat urgent intervention for tether cord. And so she said, and I said, "Oh, I'm going to have to talk to the patient and kind of consent her for surgery, ask her about her symptoms." And then my resident gave me this. She said, "No, she's told me you don't even have to talk to her. She just wants to feel better, but that's what she feels. She just wants you to read this." And I looked at it and said, "Electrical waves, entire body, extreme nerve pain, stiff, inflamed, inward pressure, suction of the chest, and then chest pain, flares, torn ligament, I can believe that, vibrating, upper legs freezing." And I said, "Oops, okay." So this picture is a physician. That's kind of amazing. And I looked at that sheet and said, "Oh, so all right, but now I know this is real. And we know it now because we had proven the mechanics. But now we're going to get back to the patient. Of course, so now, so we understand now there are symptoms that are not in the textbooks. Okay, so how are we going to measure outcome? How are we going to grade, success of surgery? If a patient is telling me, like, "Oh, there's like a cell phone vibrating in my, leg," I said, "Ugh, okay, well, how do I grade that?" So understand, like, all our outcome scales are not valid for tethered cord. When the reviewers, they were always coming back, "Oh, Dr. Klinge, you didn't use the outcome scale." I said, "Oh my God, can they just stop?" Like, they didn't understand that there is no tethered cord outcome scale. There is a German neurosurgeon, like I admire him, I value him, Dr. Kleikamp. He published like 20 years ago about like an outcome scale in tethered cord, but he used it from spine. And it was like, you're either paralyzed or not paralyzed. I said, "Oh God, no." I mean, I'm glad that not everyone is paralyzed with tethered cord. So you can't use these traditional scales, But long story short, so Kyle McDonald, the director of visual arts in Rhode Island, or the healing arts at Lifespan, now Brown Health, of course, now no Lifespan. She came and said, like, "We love to do something medical and visual." I said, "Oh, you got me." So we have these things that patients cannot describe, and I'm sitting there like 10 minutes waiting for them to describe their leg pain, and nothing comes out of them. And so I said, "Yeah, so maybe if we would picture this, So what we did is, and I want to just mention Ashley Choi. She worked with Kyle. And she was an undergrad student. And so she sat then there, maybe some of you even remember her, and was, when a patient said, "I cannot describe my symptoms," we said, "Okay, come up with something creative. Just tell us what it is." And so she recorded all these creative non-textbook symptoms. And then and we got like, we used 27, participants. And then we, got like 72 creative symptoms. And then we ranked them, like what were the most frequent, We took the symptoms that were reported in more than 20% of patients. So imagine symptoms that are not in the textbook, and 20% of patients said the same thing, So you can't make that up, right? And I always tell my residents, like, of course, you can say you don't believe like these subjective complaints of a vibrating cell phone, but if 20% of people tell you that, I mean, they're not all, like, meeting in front of your hospital and telling you, tell Dr. Klinge that I have a vibrating cell phone in my leg, So what we did is we gathered those, and I'm just going to show you some pictures. And this is what Ashley Choi did draw. She is, an art major, and and then we categorized them. So when we were trying to understand numbness and tingling, people were saying instead, like phone vibrating in my pocket, buzzing. So she got this picture, and then people see, like muscle feels like a knot. My leg feels stuck when I walk, so she draw this picture, and then often people say, like, well, my leg gets tired. And when I say, does your leg feel tired? Oh yeah, it feels tired, but it's more like, I need to massage it all the time. And, if it's like running on just one leg, my leg becomes so heavy. And actually, like want to say one thing, kids with tether cord, the first thing, they ask mom and dad to massage their legs, even though when they cannot really talk much about their pain. So that is a very important biomarker. This is, like my legs feel like lightning, like an electrical shot. She came up with that picture. And then also sometimes people feel like my legs are just not mine, they do their own thing, so I have very little control. They feel like disconnected. Sometimes it's also like that, so only the leg feels disconnected, but it feels like the upper body feels disconnected from the lower body. So what we then, and then of course, that for me was, so I didn't, so when I said, like, well, your legs feel heavy, and then one patient was telling me, it feels like an elephant is sitting on my legs. And then all of a sudden I was picturing that elephant, like sitting on the legs. I said, oh my God, it's horrible, an elephant. So that is my favorite picture, because when that patient told me the elephant thing, I said, wow, well, so, but then, understand that that elephant came again, another patient, and I didn't say, is it like an elephant? No, the patient told me, another patient told me again, it feels like an elephant. I said, okay, yes, this elephant. So I think you understand my point. I'm a scientist, right? And here I understood, that this is not just a coincidence or like something weird. And then some people feel like that there's water dropping down their legs, but there is not. So we are now doing phase 2, and please tell Anna Seni that I showed a picture. She is now validating the scale and validating the visual qualities. And real quick, this is our project. We started last week to ask now every patient before surgery, so now we want to grade it, but we also want to validate it. So we are asking now, of course, which leg, but then we want to grade it, and you see how the elephant gets bigger and bigger, So all this, the visual and analog scale, right, with the smiley. So this is kind of in sign kind of like that, So this is like the elephant, like the big elephant, and then left and right leg, and then here, the knot, and again we ask, is there any trigger? Because we want to also understand more, are these visual complaints also correlating with like events, when I walk my dog, or when I like sit, or when I have to do this and that. So here the knot gets, like a little bigger, and, the tightness, in the leg is like shown by these little, like little lines. And then I like this one. Of course, he's only yes because this is both legs, right? There's not left, right leg. But look at this. Your legs are gone, like when you are more severe, So kind of, like, I hope not everyone is there, then really have to do something about it, So, and then this one, is probably like easier. She just shows more light, and so this is some examples. So, but the thing is now, we show these pictures first, okay? And then Of course, now I'm telling the trick already in case someone comes next time, but that's okay. But then we ask, like we give a questionnaire, and then we ask, like, and then we say the words that have been traditionally associated with those visuals, and then we'll see whether it matches, that if someone selected the leg with the lightning, do they also select the wording here? Anyway, so that is our most recent project, and we're hoping that we're coming up with that visual scale that will then also allow us to more reliably measure outcome. So one of my really favorite subject, was the getting us back to histology, was also understanding that, of course, we can have a bad phylum, but the phylum is also doing still something. There is a physiological function in the phylum. And like, I don't know whether you remember in our last, I'm again saying a pre-pandemic talk, Abby McElroy, who's a veterinarian doctor. She's now, yeah, right. She's now doing genetic research. Yeah, she talked once, right? And so me and Abby, we spent weekends, like that's the two of us, over the microscope, and we looked at ultrastructure of the phylum, as you know. But the thing is, we didn't just look at the collagen, which I already showed you. We also looked at, what about those nerves? The pathologists always report like nerve twigs in the phylum. These guys, are these nerve twigs, and this is fat in the phylum, and then you feed. And then when I asked the pathologist, what are those nerve twigs? Well, we don't know. These are like chopped up nerves, maybe. I said, well, so we said, okay, let me look at those nerves, And when we looked at those nerves ultrastructurally, like transmission electron microscopy, we actually saw that these are all like nerve endings, not nerve endings, of course. I mean, like pain receptors, like nociceptive. So you are familiar with pain, but every pain researcher knows these Ramak Schwann cells. These are these guys. These are non-myelinated nerve axons, that connects directly to collagen. So their nerve meets collagen, and these Ramak cells are because, like the, collagen, can trigger, like pain due to stretch forces, and these nerves then sense the pain. And Ramak cells are really well researched in pain science. And so these nerve twigs are basically pain receptors. And then also not only pain receptors, they are also Ruffini mechanoreceptors, like mechanoreceptors. So the phylum senses stress and strain, which we would think it should, because we just said it's a ligament, but this has never been shown. So these, this is a Ruffini body. This is not they are usually in the skin, in the skin. We have mechanoreceptors, obviously, we need that for protection. This is in the phylum, and they have never been described in the phylum. And so again, nerve meets collagen, collagen stretches, and probably that's also what my phylum should do. Like when I shouldn't overstretch if I, don't have a hypermobile condition, because my phylum might be telling me, hey, I'm going to shoot you some pain in your back so you don't overstretch, So this is what we found. And then we said, okay, well, great, now we have like some mechano or nerve endings, but we also wanted to see, so what are they doing? Are they just kind of shooting some pain up, or are they also doing something more? And we found out that these nerves in the phylum, they talk to our entire paraspinous muscles. What we did is in the surgery, so bear with me, that is a patient on the belly, this is our incision to the spine, you know how that looks. And so when we approached our phylum, as you can see here, opening of the dura, phylum on the nerve hook, this is a fatty phylum. I put this picture in the publication, even though I don't deal with a lot of fatty phylums, but at least that the reviewer sees, oh yeah, this is really a phylum. Otherwise they would say, what this is, what this is this for a thing. So I showed this fatty phylum. And so when we stimulated the phylum, we got also, so we put needles along the entire spine, like EMG needles, like muscle recording needles. which we do usually anyways in the phylum surgery, because we do put them in the legs, because we have to make sure that we're not cutting into a nerve that supplies the leg, even though we usually don't cut into nerves because the phylum is a very distinct structure, as you know. But anyways, we use EMG monitoring to differentiate the phylum from the nerves in the legs. But now we also wanted to see, is there any signaling to the nerves in the to the muscles in the paraspinous area? And when we stimulate the phylum, we got signals from muscles above the surgical site. So basically, the phylum is somehow connected with the paraspinous muscles, even above the surgical area. So that means that the phylum gives signals, up. And we were speculating that maybe the phylum is connected somehow to the paraspinous muscle network, not muscle, nerve network, and thereby, communicates and also controls the muscle activity. And with cell cord, we have muscle spasm, we have chest pain, neck pain. That might explain, where we have spasms, because the phylum has, retroactive communication through paraspinous nerve networks with the paraspinous muscles. And you can just hear, here we got the responses. These are EEG responses from the muscles up here, way above the surgical site. So that was kind of exciting, which then now gets me to presenting you our next high-risk research study. We'll see how that goes. But we got some funding for that. And so basically our assumption is that our phylum, is connected to all these little segmental, paraspinous nerves. These nerves are at every segment, and they segmentally control, the tiny muscles, along our spine. And it looks like the phylum is involved controlling those. So that was very exciting, and certainly, like that also explains the back pain. So that's why I found this little, of course, the disease phylum hurts, pain. So so our study now is, and there's only 2 slides because we just started. So we want to show, is it that the phylum, causes, segmental control of paraspinous muscle activity in anyone? So we are putting surface EMG electrodes on the spine, and we record, like the activities of the paraspinous muscles EMG while someone is walking. And because of walking, you move your phylum, right? So that would give evidence that there is a segmental control. And then we're doing it in people with hypermobile EDS and Taylor cord syndrome, where we think it's not working because the phylum is diseased and not functioning. And then if we have a difference, then we see there is something wrong, with the segmental control, which would explain a lot of symptoms. Then we do the surgery, and if it gets better, we have a lot of proof, that the surgery is really doing, like a mechanistic thing to body posture, body control, basically the whole truncal control. So we are having our, like Center for Innovative Neurotechnology and Neural Repair. It's at Meeting Street, I think, right? Is it at Meeting Street? Chapman Street. So this is our flyer that we give out now. People are coming, they get all sorts of like EEGs, EMGs, all surface skin electrodes, no needles. And then we ask them to move and do certain things. We record this wireless, like mainly wireless, right? So then, we get like a little, like a little sketch here of your movements, and that allow us certainly also to record the muscle activity. And this is just showing you that it's a very involved and intense study. Not so much for participating, it's just like for a few minutes or so, moving and walking up and down. But technically, it's quite involved. But we are very excited because that would get us to the next level. So the diagnosis. Quickly, the diagnosis. The paper on the occult tethered cord syndrome. So what I want to really extract out of this publication is that besides the fact that tethered cord is a conus dysfunction, which everyone has believed, in kids, of course, oh, tethered cord, oh, bladder dysfunction. Sure, because this is what is found, when you do a urodynamic testing. But in our early publication in 2022, we had shown that the urodynamic study is not always, diagnostic. It can be normal, and yet you still have to report. So we were looking for other biomarkers. It can't just be the bladder. And like Taylor-Court syndrome is a triad. Triad clinically means, like 3 categories of symptoms: leg weakness, leg fatigue, back pain, and urinary. So we were looking more for like a neurological biomarker besides the urodynamic biomarker, which isn't such a good biomarker because sometimes you don't always have this, what we call the true sphincter dyssynergia. I always break my tongue when I have to say it, but that is the classical thing, which is we found it only in 25% of people that had a true Taylor-Court syndrome. So it's not a relevant marker. So what we found, and I know you have read the paper, many of you, we found that we have a neurological biomarker, and that biomarker, is increased muscle tone, hyperreflexia in the lower extremities, and clonus in the foot. Clonus is like when you take the foot and move it up. There's a little wiggle that only the doctor can feel, and that is a sign of spinal cord stress and strain, basically a sign of a strain to the motor neurons that run through the spinal cord. And those, in conjunction with other subjective patient report pains, made it into a 15-item scale that now helps us to more reliably diagnose the syndrome, as well as predicting surgical response. So that's why, we are a little bit in a pickle because, of course, as much as we these days want to do like video conferences and televisits and help out, but that cannot be done, I guess, through a video conference. And the thing is, this is a learning curve as an exam. I can talk to another neurologist, but they would, you have to also train people on that exam, in other words. I don't mean to seem arrogant, but it's really like an exam that is very subtle. You don't go there and you have, sometimes, of course, you have very brisk reflexes, but sometimes it's very subtle. And often it's also asymmetric in Taylor-Court. One leg is more obvious than the other, But what the best message is here, if you have all these symptoms, all these findings, upper motor neural dysfunction, but you have a normal MRI, there's nothing wrong with your spine, but then it's got to be Taylor-Court. I'm even sometimes successful to convince, like an insurance doctor and a peer-to-peer that, what else do you think it's going to be? And they said, yeah, that makes sense. So, okay, so our score also allows us to predict a response to shunting, to Taylor-Court surgery. Yes, my hydrocephalus brain. So if you, item score, if you score 11 out of 15, you have a 90% chance of improvement, not fix, all that. But I want to warn you, so this is one publication, okay, out of, I think 142. I mean, as a researcher, I have to say, we cannot, I would not walk away from someone that has maybe just 6 out of 15 points or less, it's certainly always unique. This is just a first step, to validate its syndrome and to see if we can quantify, surgical or even predict surgical response. It's just like, this is not the Bible, okay? But I'm kind of proud, and this is the last part of my talk, that we were able to establish at least a step towards a scale. I told you, 15 years ago, they took the spinal cord, paralysis scale. That's not what we're dealing with, Of course, it is disabling. That goes without saying. But there are other signs and symptoms. So I'm so proud. We had once, it says Taylor-Court. I don't know why they might, So this is from artists from the Rhode Island School of Design. They were invited to go to our OR, So of course we had to approve it, So we had once these art students not running around from one OR to the other, And then for some reason, I take pride in it, they like to spend time in my OR room, So they were kind of drawing, I don't know who I am here, but it doesn't matter. I think maybe I like to be this one, very focused. So they were drawing the T, techs, nurses, and then of course how we opened the dura, and then the phylum, very very good. That's how the phylum looks like, with these little arteries here, And then, of course, yeah, I put it on my nerve hook and I snip it, So this is now in the OR theater. When you go to the room where I'm doing surgery, the orange room, you see that there, And, I cannot take enough pictures of it. I just took this last Wednesday. I said, oh, I have to show it, oops, sorry about that. So, really quick, as you know, and that again is pediatric neurosurgery. So what is new? I have to say what is new since I saw you last is that now we really have learned, or, I have pioneered the way that it's really possible to get the whole phylum out. In the past, even I was just snipping it or taking a piece out, but there is some value in like really, it doesn't mean that everything was done wrong in the past, but I have learned, to really, when you go high below the conus and you cut the phylum here, you can get like pulling from here, you can get the phylum out. I tell you in a little bit why we would do this, but we were able, or why it might be beneficial. It might be beneficial. It's safe to do. Let me put it that way. It's safe to do. And do I have to? Oh, there. So this has now really. So of course, this is a drill opening. We are lifting the phylum on our nerve hook. Okay, that is a pediatric case. This is a video that we published to show that you can actually remove the entire phylum. We stimulate the nerves, and then we get the leg signals, or even paraspinous signals, as I told you earlier. Then we stimulate the phylum, and sometimes we still get results from phylum. I told you the phylum has nerves, like these pain receptors and these mechanoreceptors. So they sometimes give you responses, and we cauterize it, But the important part comes in a minute, where I show you. So now, this is now the piece that is the sacrum. See, you're pulling a little bit, and see the whole thing comes out. Yeah, see. So that is so. This is now what I teach this to my colleagues, and my colleagues are convinced that this is a good thing. Even my other partners, they're doing it now that way, and they agree it's safe to do, and that way you don't have any leftover tissue, no leftover phylum, and so see, this is a picture of how it's kind of like how it ends up looking if you only take a piece out, So see, this is a lumbar MRI. And this is the steady thing here is the phylum, and you can see here that's where the surgeon went in. Of course, we did acknowledge that the rest of the phylum that's still hanging on the spinal cord can reattach. That is acknowledged, because fat likes collagen, So ideally, you should get the whole fat out, but also the distal piece, that retracts into this lower canal, can also get kind of reattached. See how it kind of bends backwards? It's attached to the dura, and it can actually also kind of aggravate or catch some nerves, some cauda nerves, and can also cause distal tethering below your sectioning. So this is actually a child that I did a couple of months ago. So this is her head this way. So the phylum was transected already. But see, this is the phylum again on the nerve hook. It's still attached, So it reattaches, and it actually catches nerves with it. See, these are nerves, these guys. So the distal phylum, the leftover phylum that has already been detached from the spinal cord, is catching those nerves, And then here you can see, like how we kind of pull it out, But so there is a point that this might be a valuable thing to do. And I'm trying to teach now other neurosurgeons. And I had presented this at the conference of Neurosurgical Society 2 weeks ago in Los Angeles. And I was relieved that people, were not like shooting me right away off the podium, So they validated that, and they said this is a viable concept. But of course, we have to prove more, We can say it's safe, but whether it's associated with approved outcome, we'll see. So this is just I'm writing that up now. Tomorrow I will continue to write, depending on the weather. So breaking news. We looked at 2011 to 2023, all phylums, classic, like the fatty phylums, hold, you know, and we reviewed the complications and the long-term outcome. We had 606, we have more, we had to take some out with not good follow-up, and so, but long story short, up to 10 years now outcome, and we had 44 patients with hypermobile EDS, 36%, 44% EDS, 36% occult, and then in 55% so far, we did a complete phylum removal. So I'm going to show you some data. First of all, I want to just show you like our short-term complications. And one thing I'd like to mention, you know, that the CSF leak, I'm not saying this in order, you know, to show off or something, but I think, you know, like 1.2% is quite low. And I believe that this fat graft, you know, the little fat that we take from the subcutaneous area, then we put it on the dura after the dura is closed here, is really preventing CSF leaks. And we've been doing this now for a long time. And it only takes maybe like 10, 15 minutes longer to get the fat graft, because, you know, not only is a CSF leak making you feel miserable, that goes without saying, but a CSF leak potentially also increases the rate of retethering. Because with the spinal fluid, you know, like it's leaking out of the site, you know, the nerves become attracted to that site and can glue to the dura. And then, you know, you get the cauda equina tethering, you know, even though the phylum is gone, the cauda can tether. And then you can see here, you know, like that is how you can see the cauda tethering, which causes the same symptoms like the tethering, because it's again tethered, you know, the spinal cord is still attached to the nerves, and when the nerves tether, it's kind of the same thing. So now we do, if we are concerned, you know, past 6 months, usually it can occur. It can also occur without a CSF leak. That's the thing. I show you the data on the next slide. It's just doing the surgery, going into the dura, causing that little scar. It cannot occur up to 5 years. You see here on the prone MRI, the nerves go backwards because they're attached. And so the good news is, there always bad news and good news. Right? So the bad news is it's 8%. I was always hoping it's just 5%. That sounds better in the realm of like spine surgery. But now with all the new data, you know, at 8%, we only looked at patients older than 4 years old, because 4-year-old is hard to say, and they still thrive and develop. You cannot really clinically establish a retethering. Of course, you can do an MRI, but it might just look like that. So, but what we found is that the retethering rate or any complication is not different in occult tether cord, whether tether cord, EDS or no EDS. So, you know, or whether we take the whole phylum out and not. I'm a scientist, I have to admit, so far the whole phylum removal has not shown to reduce the retethering rate, even though I was hoping, but I have to be honest to myself. That's why we analyze data, right? So we can't say anything just out of the. There we go. So you can offer a second surgery. This is just a patient I did recently. You know, you go to the same spot. You know, this shows you here like how the nerves are kind of attached to the suture. Oops, sorry. And then you'll take your little, you know, like your little hooks, and you release the nerve slowly. And then it looks like this, you know, or like this, pretty good, you know, the nerves look clean again. What can be done, and what I've been doing now more often, is adding, you know, like a duroplasty, meaning like you widen the dura in order to help that the nerves don't attach too fast. I haven't been doing this at the beginning, but then, yeah, well, you know, like if you listen to other people, then I guess you also get new ideas. Some of the spine surgeons that deal with a lot of, you know, like tethering for other reasons, they sometimes put in duroplasties to get the nerve away from the dura. And so I said, okay, well, that's probably an opportunity. This is a lady I did like a couple of weeks ago. You see here the prone MRI shows the tethered nerves. Sorry about that. We did what we did in the other slide. And I showed the duroplasty, and you see it post-operatively, you can see, you know, the nerves are all released. They look nice and aligned. And the duroplasty gives this black is the duroplasty. It gives that extra space. So I think, you know, in cauda tethering, this is an option. What can we do? And I'm almost done. almost. What can we do or what can the surgeon do, you know? And then, of course, we can talk a whole day about other options to minimize arachnoid scarring. Uh, so it's another universe. But what can we do? Of course, you know, we can really train ourselves to just do very small openings, you know, in the dura. This is just 3 mm opening, to not mess with the arachnoid. The arachnoid is the spider layer that is around the nerves, and that's what scars, you know, our arachnoid layer. That's what retethers the nerve. So I wish we had no arachnoid, but I guess, you know, God gave us the arachnoid, but that's also the tissue that moves our spinal fluid. So we need an arachnoid. When we, you know, like when we close, you know, a dry surgery, no bleeding, you know, no blood causes inflammation, you know, then we trimmed down our sutures. We went from a 5-0 to a 6-0 now, a very tiny suture, so not to have too much foreign material, you know, that can cause inflammation. The 6-0, and then like the small opening, the small closure here, you know, and then of course still the you know, like fat graft. You can see here how this is the dura and that is the fat, just about to put it on there with a little bit of a tissue glue, you know. So basically, small opening, dry surgery, tiny sutures, tiny closures, CSF rate 0. I think we should accomplish this. And full phylum removal so far hasn't shown to be beneficial, but it is safe to do, as I told you. The one thing I want to share with you also is, you know, like, okay, we'll talk about complications. CSF leak rate really is not high. I can say this with good conscience without blushing. Of course, we have to deal with retethering. This is something that in future we have to address. And I take that very seriously. Surgical technique is to be refined. But what we have to say, you know, the outcome is quite good, you know, like with our promising. It's not a fix. It's maybe we shouldn't even talk about outcome. You know, outcome is such a definitive thing. You know, like outcome, it's good or bad. You know, we are seeing change, right? We're seeing hopefully good change. We are seeing improvement. You know, that is also what this graph shows. You know, with our 15-item scale. You know, the 15-item scale, we could show. You know, that after 3 months, you know, 89% of patients show improvement. You know, this is the bladder score, you know, after 3 months, improvement in all bladder function, pain improvement, but certainly more spread. And then, of course, the neurological score, you know, like drops down. While the neurological score maintains to be pretty dropped down after 1 year, pain goes up again, a bladder goes up again, and pain goes up again. I would say, you know, like, I mean, you all know pain has many factors, because after a year, the pain gets confounded by other things. I mean, I don't have to discuss that here. That's probably what that reflects, because we might need better pain scales also. Not, you know, yeah, I hear you. Okay, I add one more project. I got it. We have to talk about it. Okay, I'll talk about the new project, and then of course, you know, like the scale reflects it. But what I want to share with you is, you know, one thing we found. It's a little something, but with the full phylum removal, this is the entire phylum out. We saw in a multiple logistic regressional model where you statistically take all variables that you want to check and measure them versus improvement. Okay, so we looked at full phylum removal, EDS or no EDS, occult tethered cord or no occult tethered cord, and what we found is, you know, like if you know, so if we take the full phylum out, and we have no EDS and no occult tethered cord, but we take the full phylum out, there is, you know, like an 80% chance that you have a good, you know, a significant improvement after 3 months. That is 3 months outcome. So if you have a full phylum removal and you also have EDS, the number increases to 86%. So you need to have EDS in order to get even better. You know, that speaks to the mechanistic, you know, thing, you know. And if you have EDS and OCTS, I mean, it goes kind of hand in hand, you know, because a lot of EDS is OCTS. So basically, we can model, you know, like various factors. But what I always say is, you know, like, no matter what, you know, like, you have to give yourself some time. When the phylum is gone, the other ligaments take over the anchoring. It takes 6 months, and symptom flares, symptom relapses, new symptoms can occur based on the anchoring. These are the dentate ligaments. They anchor the spinal cord on every level. And that's, like what then becomes the healthy part of the spinal cord anchoring. Sometimes we help with little mineral dose packs, steroids to, assuming that there's some inflammation with flares, but we hold tight in the first 3 to 6 months, which is the hard part. But that is, like how we see it for now. Of course, our heroes are the physical therapists. I cannot say it enough. One slide is not enough, but they certainly help us in that process. I want to, before I give you my surprise, so I want to raise the level of excitement, hopefully. I want to tell you a little bit about extradural phyllo procedure. I'm doing this for Dr. Chopra, okay? So you know Dr. Chopra, right? A lot of you. So he is a little bit concerned with the, of course, we talk about extradural, and the rationale, basically cutting the, so the phylum that we talked about like for an hour now is the internal phylum that connects the spinal cord with the dura, but then it goes into an external phylum that is in the sacrum and it connects to the coccyx, So I don't know why, but I guess people always assume that this is one thing. And, in Europe, I don't want to mention the name of the center. I want to be respectful. They do the extradural. And I hear from other people, like I get people, I talk to patients from Belgium, Germany, all sorts of countries, and they tell me sometimes that they have some benefit. I also have people that had only short-lived benefit from extradural procedures, and then and then Dr. Chopra called me one time and she said, Dr. Klinge, are you now telling people to go to Europe and do the extradural phyllo procedure? I said, really? Why would I do this? And then he said, well, so I said, no, I'm just saying I have to be a scientist, I have to be honest, I don't, how would I turn down a new procedure or a different procedure, So I think, maybe it helps a little bit. But the thing is, if you cut it, maybe it relaxes the dura, and that way it relaxes the internal phylum. And I thought you might want to appreciate this discussion because people ask me, a patient asked me. The thing is, there are two studies, that show that it might kind of not work, but if it works, then we still have to find out why, because the intradural phylum and the extradural phylum, they're not connected. So this was a study from Philippe Deflo, my friend in Belgium. He did cadaver studies and looked at the phylum. This is the internal phylum. This is the external phylum, and here is just dura. And this is, there's nothing. The dura is the barrier between them. And then not only in Belgium, but then also Shane Tubbs, who worked with Jerry Oakes, very well-known pediatric neurosurgeon in this country, Tubbs. He looked at, mechanical relationship between internal and external phylum, and he took cadavers and then he did some pulling. This is the external phylum here. That is the dura with the internal phylum, and he pulled and he measured then stress and strain, pretty much what we did in the internal phylum, and there was no transmission. So the external phylum kind of, and so forgive me, but this is science that I'm presenting, but I still think, because I do know that people do better after the external phylum release. There's got to be also some mechanistics that we still don't know, and maybe that is not the right way to prove or disprove it. But they say based on our findings, extradural phylum transection is probably inappropriate, which I am surprised that the editor allowed this statement. You shouldn't say inappropriate in a scientific article, If I would be the editor, I would have just told them further studies are needed to prove or disprove it. But anyway, this, of course, we don't have a day to talk about that. I'm looking at Ellen, and also, it's okay if I mention Shayna, right? We are trying to get a, like a write-up, it's just hard. And it's getting harder, with all the limitations. I mean, we are no saints, right? We are no saints, but we're trying to be better. With pain management and patient services. And I know you were helping with this, but I just want to make sure. This is my you know, if I were to pick a hospital, this is how my hospital would look like. So you, oh, just so you know, this would be your bed, you know. I would come and serve you a bottle of wine and champagne, you know, and then you know, like we can watch a movie, you know, and just be happy. But well, you know, uh, maybe in another life, we'll see. So the surprise. So I told you at the beginning that we have these mast cells in the phylum. Of course, you know, at the moment, so Dr. Maitland said, yeah, I would have told you like 20 years ago that you're going to find the mast cells in the phylum because the mast cell disorder. I said, mm-hmm. And then, of course, I believed her. But then I never did a study, and forgive me, really to look at mast cell disorder and the prevalence of mast cells in the phylum. But mast cell disease is also not well defined. I mean, you agree with me, right? So how do I do, like, I guess it's a not easy study to do. But then, you know, like I told you, it's not just the mast cells that we find in the phylum. We also find lymphocytes and macrophages, the CD45 lymphocytes. These come from the peripheral blood. And so then someone saw this publication. This is from our World Neurosurgery publication, like the EDS filer. And Mike van Eltzacker, he's a neuroscientist at Harvard, came to me, and he actually had done a connection, and he already started some connection with Dr. Bolognese about, like, he looks at, you know, like inflammation in connective tissue, more from coming from the you know, like long COVID Lyme disease perspective, trying to prove long COVID and trying to prove whether these viruses actually make it in our tissues one way or the other and affect disease, you know. And he said, and he told me, you know, like, like I said, yeah, I know people have onset of symptoms after COVID or after Lyme. We know that, but we cannot make any sense out of it other than saying it might be some neuroinflammation. He said, well, why don't we look at the neuroinflammation? Why don't we look at the specimen? And so I said, okay, well, we have enough phylum specimen. And then we started an IRB, and we were allowed to do material transfer. I know it's a lot of work. Thanks, Amanda May. That takes a village, but we made it. So what we found so far, and we just had the 2 weeks ago, the meeting, it took them a while. So we took the patients and we stratified them in those that truly had proven Lyme disease and then had COVID. And were also diagnosed by some expert with long COVID. And we took those phylums and took our control group. They definitely had never had a Lyme, they never had COVID, they never had anything, you know, in their history. And these are tether cord patients. So we have these Lyme COVID patients, and we have the non-Lyme, non-COVID patients. And so what we found was amazing. And that, you know, like I was, you know, like I couldn't believe it. And I never thought it was going to turn that out. So this is this is a lymphocyte, and we found that so we sent them a little muscle fascia, we sent them a little fat, we sent them a little here, but we also sent them a piece of the phylum. And in the phylum, they found a higher, you know, rate of like CD45, you know, like amounts in the phylum in the Lyme and COVID population compared to the ones without. And this is a huge difference. This is so significant, you know, that there's not even an overlap between the two groups, right? You have a box plot. Box plots are always the most honest statistical boxes that you can do in science. They're not even overlapping. So it must be, you know, that there is some peripheral immune thing also being part of it, you know. So the CD45 leukocytes, you know, they are infiltrating immune cells. And if you have high CD45, that is not from the phylum, this is just like generally, it suggests an active inflammatory response of peripheral immune infiltration. So in relation to tether cord, it could be that the CD45 positivity marks an immune footprint within the phylum terminale, a low-grade inflammation, you know, likely reflecting crosstalk between the central and the peripheral immune system. So our phylum is maybe a biomarker of something. You know, I mean, that's not why we're going to do surgery, we're going to do it because it's tether cord. But there is more to it. And this opens up you know, a total new universe. Not sure which, you know, now there are 10 paths open. I don't know which way I'm going, but still a surgeon, you know, I think we're still going to do surgery. So this is the team, you know, Amanda and May, you know, came. We have Natalie, our resident, and Leila did a lot of work with us, and Owen oversees the team. You know, he is, you know, certainly also doing his PhD thesis and is very busy, but he's always there for us, right? Day and night, you know, so that is true. So, you know, like what is most important, and I have to say it, you know, I have to say two things. If I didn't say it enough, all this would have never ever been accomplished without you. You should know this, you know. Whatever, you know, maybe I shouldn't even say this as a doctor, but I'd like to say it. I hope you know it comes from my heart, because your trust and your dedication, the ideas that you gave me, and everything, you know, also, you know, like bearing with me, because I'm still just doctor, you know, so means a lot. And I always say, you know, like to the medical students, I say, you know what? Ever since I took care of patients with connective tissue disorders, I felt that I went to medical school again, and I did it all over again. But this time, I was taught by the patients and not by the professor. Thank you.
All right, we'll go into some questions. I am going to pull up the Q&A. Okay, so we have a couple here. If you'd like to answer them.
Yeah, sure.
If you could read them out loud.
Yeah, okay. I'm curious about CCI after surgery, after telecord surgery. Are there contributing factors for why a person gets worse versus one that has improved symptoms? Yeah, so again, I mean, that scares me too, to be honest. So I wonder, you know, and that's why we are doing this high risk ENG study that I told you in our Cine lab, whether when we cut the phylum, there's so much new anchoring going on with the dentate ligaments, and then also the rearrangement of the paraspinous muscles, that this might mess with it. You know, adjustment is not always good, right? You have blood pressure, you give a blood pressure pill, and the blood pressure pill might do the wrong thing. You know, you have severe headaches and it blows your head. So it could be that so my theory is that this adjustment period is so much stress for the body that it affects the CCI. And some people get worse and some people get better. Oh, I have done a question. Oh, I have a question when she's done with her presentation. Is that the question?
Yes. Yep.
I am a provider who cares for AS patients and offers SPECT OTCs. For the workup, I often cannot get insurance to cover MRI for the entire spine. What sections are absolutely necessary? Also, if patients cannot get urodynamic studies, would you accept VCUG, which is a video? So yeah, oh, thank you. She says, thank you for the work. First of all, lumbar spine would be just enough. You'd be surprised, sometimes that doesn't even happen. I see people without MRIs, without any films. I started, particularly kids, but also I would do this with the adults as well. And then I order whatever I need. So my team understood that I'm the only surgeon that sees people without scans. So ideally a lumbar MRI, but I can see without scans. We just have to communicate with my staff because they always look at me like I had 4 heads. But it's okay. And then urodynamic study, it's not necessary to see me to have a urodynamic study. The urodynamic study, we don't need to do this. I will decide, but the VCUG is good enough. But even just having seen a urologist sometime, if you had a urology appointment like a year ago or 2 years ago or 3 years ago, and you hadn't done a urodynamic study, at least having an office note from a urologist would also help. It's not mandatory to just see, you know, like what did they say? Because at the end, what do we have to prove? We have to prove that the bladder is not like duplicated or lopsided or like something, you know, we have to prove basically it's okay bladder, but it's not functioning. So there's got to be some signaling going on, and it must be tethered cord. Basically the answer is I can see without MRI, at least lumbar, no bladder study needed. If there's some bladder consultation, that will be good. I live in northern Vermont. Oh, no, not this.
I want to jump to a question in person maybe, and then we'll go back to online.
Sure,
we'll do like 2 and 2.
Okay.
Okay.
Sure.
So hands, please, if you have questions, and then she'll call on 2 people in here.
Yep.
What can we do to help this program?
You mean upright MRI, right? Upright.
Yeah.
Yeah.
A lot of people have odds.
Yeah. The upright. Yeah.
Can you repeat the question?
Yeah. So Ellen Smith is asking what it needs to take to do an upright MRI, right? So I had done some work on that as well. So the problem is you need to have what's called a certificate of need for the state of Rhode Island. And I spoke to the chief of neuroradiology, and the certificate of need means like it's almost like if you apply for a bill, for the kind of thing, that it has to pass, and it has to pass the state of Rhode Island. And the problem was like 2 years ago, they already approved 3 MRI magnets for routine clinical purpose, one in Miriam, one in the Collier Street. So they had no need, So basically, it would be asking again, which we could do. But the thing is, so writing a certificate of need, is like I would write 10 R01 grants. R01 grant takes me half a year. R01 grant are big grants to the NIH. And I saw the requirements. We have to prove the numbers. We have to do budgeting. They have to understand that we make millions of money out of an upright MRI. So it is just too much for one doctor. And I couldn't, I don't think even if you were to help me, it's like I don't think that is something we could accomplish together. I mean, of course, we can go to Washington, and say, hey, we need see. I don't mean to be sounding silly. It's just for now, I don't know where to go. The only thing is I can ask again our department chair, the new chair of neuroradiology. I wouldn't mind asking to see what would it take, because I agree with you. We are in need. Yeah, absolutely. Oh, yeah, and it's now. Yeah, and also now with this research I didn't present, because we are now looking at these ligament bridges and the myodural bridges at the base of the skull to support the Chiari zero and ABS. You can see them in the upright MRI. We're only looking at the bone angles, but no, they're also good for the ligaments, not the skull ligaments, but the ligaments that are attached to the dura. Okay, all right, yeah. But you remind me, I'm going to ask Dr. Mahesh again to see if there's now a better chance. But 2 years, I know. Yeah.
The closest upright MRI is in upstate New York. If you don't know. So that's why it's such a big lift. It's like 5 hours of driving to be able to get there.
I know there's one on Long Island.
There's another one there as well. Yeah, but New York, you have to go through.
Yeah, there is one on Long Island, because I have a friend that just had to have one that lives on Long Island, and he got it. And when I was talking to his wife, I'm like, "Wait, you have one right there?" And
I didn't know that.
I was like, "Oh, no," because that's like if you took the ferry over.
We have a ferry from Connecticut.
It's not, then we can do that too.
First time I like travel is prohibitive. 5 hours on a ferry within 100 feet.
Yeah.
Even going to Long Island.
I'm not saying it's easy. I'm just saying there is one on Long Island as well. That would be.
Not as.
I don't know if that's closer than the one in upstate. It's.
Right where it's Sleepy Hollow is one right there. Closer than trying to go back. But anyways, looking for that's where I had my. I was going to go up to New York because it was hour-wise, the further, but from Rhode Island. This one, I'm too northwest Boston, so the that are spinning difference.
Ah.
Well,
So Long Island.
it's not
Yeah.
Long Island.
Oh,
It's right on, you go over from, is it Yank or whatever, that
Mm.
road where you go over, go to North New Jersey.
Mhm.
Around this side, it's
Oh,
just in Connecticut, it's just, right there. I'll look it up. It's on my record.
yeah.
I
Okay.
haven't done that.
Oh, you. Oh, okay.
Yeah,
Yeah.
yeah.
I can look it up.
Do one more input.
Yeah, you had a question?
Yeah,
Thank
the
you.
surprise portion, the long COVID. And I'm trying to understand, like, because I didn't get diagnosed with hypermobility Ehlers-Danlos until after long COVID, so is it like I don't understand the relationship, I understand the neuroinflammation aspect.
Mm.
So I just wanna get like the takeaway, because I
Mm.
think what you said was important to me, but I don't understand.
Yeah. Well, no.
Repeat the question.
Yeah. Oh,
for
yeah.
people
So the
online.
question is like here's a participant in the audience asking, got diagnosed with hypermobile EDS after being diagnosed with COVID, right, or Lyme. Yeah, Lyme disease. Yeah, and so the question is how our findings of the CD45 or the inflammation of the phylum could even explain then getting diagnosed with hypermobile EDS or developing even a hypermobility. That's your question, right? So I have two answers. One answer is maybe not dismissing it, but could it be that it's just you had the opportunity to get diagnosed because you had started to have symptoms, and someone was also looking at could that be like a connective tissue disorder? But the other thing is I think it's also known that like inflammatory like viruses or inflammatory processes, for example, also toxins or so can affect the collagens, and not just genetically, but like as a secondary insult, and then you can develop like a connective tissue disorder, or if you already had it, like sleeping in your body, it then had become more prevalent.
Yeah, they got like it was.
Yeah,
It was
got
not a big
worse.
issue.
Yeah.
That was a big issue.
Yeah, so like any neuroinflammation can aggravate pre-existing conditions that were silent for such a long time. So I think he just got exposed to more diagnoses, and that was one of them, but also it might have aggravated it. So we don't know. I mean, certainly, like neuroinflammation is a big field, and it probably can, like tick off a lot of silent diagnoses. For example, normal pressure hydrocephalus, my other specialty. People after pneumonia or after Lyme or the infection, they all of a sudden become symptomatic from normal pressure hydrocephalus, and they had it all their life, with these large ventricles. So there is this, stimulant in that.
I'm going to break this down. All right, so the next question is asking if you've had multiple MRIs and they aren't showing anything, what other imaging or evidence could you bring to your doctor to help them potentially look into a cold tebet cord?
If the imaging doesn't show anything.
Correct.
Yeah. Well, the thing is, first, so for now, the biggest evidence really is what I presented, what we also published is that exam. So basically, there is no better imaging. I mean, of course, you have to have your brain, spine, and it's not showing anything. That's it. There's no better imaging that can potentially show more than the other imaging is already showing. So you need to have a specialized evaluation, and that evaluation is someone listening, figuring out the symptoms of the triad. Is the back pain, the back aches typical to what I hear? Do we have the leg weakness, leg fatigue? Is the exam showing the hyperreflexia of the lower extremities, the tightness in the feet, the clonus? So it's a clinical exam that is needed. So we cannot go past this right now. Are we gonna in the future having better MRI techniques? Might be. Of course, like there's now like 7 Tesla MRIs and MRIs that show, like maybe more dynamic imaging. Can we maybe in the future do an upright MRI with extension and flexion, and then with the help of AI, simulate, what will happen to a body if we were to overstretch the phylum. So can we simulate a disease in a certain person, you know. So I go on the scanner and they would modify my phylum and I would just stay fine, you know. So I think in the future AI and more dynamic imaging would be helping us, but that is to be shown.
You had a shout out from someone saying that they really liked the visual scales that you shared and that they were spot on.
Yeah, see, tell Anna Sami.
Absolutely, it's great. And then the next question is, can scoliosis that's already severe get worse after retethering?
Worse after retethering. Yes, it can. Any tethering, you know, affects, you know, like you know, like the strength of the paraspinous muscles. And now we're even thinking of some connection through these little tiny paraspinous nerve networks. The answer is yes. Yeah.
We'll go to 2 in-person questions.
Yep. Mm-hmm.
Well, PPS is a disease of excluded. What, if any, genetic or blood testing are you aware of, and what is the accessibility?
Yeah, I mean, for as far as I know, for hypermobile EDS, there's still not a kind of gene out there, right? I know, I'm sure you know Chuck Norris and his lab, you know, and he's, I mean, I'm not in constant communication with him, but I know that he's working hard. I guess there are some markers that he had found are upregulated, but I don't memorize them. I think so. So genetically, it's still, you know, like not a diagnosis like that is based on a gene defect, but I know that Chuck Morris is close, and I know that he already found there are some publications out there. I can find them and then maybe share them.
Yeah,
Do you have them maybe?
Yeah, I already have. I watched like I was telling you, I saw him up at UC.
Yeah.
I can send you the video of his presentations of what they're doing.
Yeah.
And they actually had a whole panel of the what's happened, how that started was like patient scientists brought that to he asked
Exactly.
his
Yeah.
one of his student scientists what she wanted to study, and what she wanted to study was finding her own condition. So like a lot of the people on that team actually have Ehlers-Danlos syndrome. So it's a great presentation, and I can send that to you. Connect with me.
Substep. Subscribe to Substep. They
Again, sorry. Yeah, so the question was whether tailbone pain or coccydynia, you know, can be, yes. The one thing is, yes, and I have also an explanation for it. So I told you even though there is no connection between the phylum internum and the phylum externum, not like a collagen connection, but most likely there are nerves, you know, that are connected, and the dura has all nerves, you know. So the phylum, and when you look at very old descriptions of the phylum terminale from Tarlov is, and Tarlov is long, you know, gone, but he was the one that first kind of tried to describe the anatomy of the phylum, and he says something really nice. He says the phylum terminale connects to the dura at the bottom of the spine, and then it merges into the tissues around the sacrum and the coccyx. So it's in continuity with the tissues around the bones, you know. So probably the disease phylum is not only giving us back pain, but also, you know, the pain triggers also go to our coccyx and sacrum. And there are sometimes people that cannot really sit on the sacrum. The only thing is what I have seen, you know, the outcome of phylum resection for tailbone pain is not so great. I have some people that say, oh my God, it's gone. And it's just, if it was just this, you know, that's all I needed. I just needed to have my tailbone. But then there are people that say, oh, my legs are better, my bladder is better, but my tailbone pain is still killing me. So, and I don't know what to say then, because I see a connection, as I explained to you, but it's not always so much of a great improvement. Maybe it's damage or, you know. You mean like only tailbone pain? Yeah, nothing. Yeah, this is a long stretch, because for now, you know, like, of course, in the future, we will look into like if patient presents with more atypical symptoms in isolation, you know, maybe just constipation or just tailbone pain or just, you know, shoulder pain or just chest pain. Could that be treated with Zelcor? But for now, you gotta have to have some elements of this package, you know, of leg, bag, and bladder. Does that make sense? particularly when it's cold, it's really hard to justify that. I wish, I mean, me, I'd like to really, tie it to a lot of things, but we also have to go by the book.
All right, we have to do two online, then we'll go back to two in person. Okay, sorry. There's a whole stack of them online waiting for us. It's okay. So just the first.
Yeah. How can teleport contribute to hip and SI pain and instability? Must be due to, again, a problem of the innervation of the muscles, right? The glute muscles or the hip muscles. It can be only that. I cannot make a connection between the hip and the phylum. I can make a connection between the phylum and the coccyx, but it's probably that that when teleport surgery is done and the muscles become stronger, then also the hip is more in alignment and it's stronger held in a socket. Same with SI. Is that you are advancing it. Oh, awesome. Who's doing it? Do you suspect teleport when the conus terminates at L2? Lower L2. I guess the question is, would I already call it like a non-occult teleport if it terminates at L2? If it terminates at mid and lower L2, that is for me already a suspicion. And I put it in my note. I say, this phylum is mid L2, lower L2 vertebral level. That is already borderline low. I suspect teleport. But the insurances don't always buy that.
Back to two first.
Okay. Mm-hmm.
Fascinated by what you were showing of the with the crosstalk we're talking about nervous system. And I'm wondering if, and I know this is this, but if there's anything on the radar in that direction with the autonomic system and being more of a wider crosstalk with the enteric system affecting the immune system. The reason being is I'm having a conversation about before about something people cannot explain in the immune system. And my question to her was, does that have anything to do with my strength?
Yeah.
So when you were explaining all mast cell, I've known that a friend of fibrosis in all over my body and getting on that mast cell activation or ketotifen, okay, especially ketotifen, gets the fibrosis down, and Costell's recognizes in me, I don't know if I'm like everyone else, but it's been a thing. So everything you're explaining is like a lot coming together.
Yeah, I mean, it goes, yes, the thing is,
so some influence on the enteric that's both together.
yeah. Yeah, probably. I mean, it always goes both ways, so that's why I said this is a whole nother universe, because it could certainly, the question is also in the bigger picture, your question is also, is the nervous system ultimately, dictating what the immune system also does, right? I think that it does, because, if you think, not only this, for example, the mid portion of your spinal cord has all the sympathetic and parasympathetic nerves, and they, of course, go to the guts, and not only to the guts, to the glands, and the glands, they are controlled by, by the immune system, or the immune system is a big part of it. So it's definitely like a circle, where things control each other. So I believe in the connection between the teleport or other neurologic conditions and dysautonomia or gut things. And also I do see more and more, because I ask it now more and more, people have this bloating or how's it called, irritating bowel disease, or IBS, and also some food intolerance. And that, of course, it could be mouths and other things, but there is a regulation, that is where people improve even after the cord surgery. So, but I think it's I don't see a biomarker right now for that. But
down at the level of
yeah.
So there's a difference
Yes, yeah, exactly, absolutely, yeah. So what we're looking in this genomic study now is not only one way, it's also looking, this study that I showed you just like the very first results of it. There's more which I don't think I should like fully show now, because there's like so much of research that we cannot even, but we're looking at more markers that would basically show also, like what you're talking about, if there is like also understanding of then dysautonomic dysfunction, like GI function, these kind of things. So that is what that study is. So, so we work hard. Hopefully, we will, I mean, we have now all the samples and they are looking at it as we speak. Yeah, yeah. Well, if we need more, we'll let you. Okay, we'll let you know. So yeah, but we, this is really like really just 2 weeks old data that I showed you. Yeah, hot off the press. That's it. For occulted cord, there's no value. I mean, there might be like what sometimes is seen better in the prone MRI. Sometimes you can see, like that all the nerves go to the front, and then that little tiny phylum kind of comes backwards. But I have the luxury that, so I look at so many MRIs, even people that I don't treat. People just send me MRIs and I look at them. And people more and more have more and more like prone MRIs now. And of course, I never examined those patients, but they tell me they have all these symptoms. And I believe that they have a cold tether cord, but sometimes I see a phylum coming out, but sometimes it's not. And the thing is, my worry is, you should not, like if the prone MRI doesn't show anything, you should not make the prone MRI now the diagnostic marker. Then you walk away from the patient. So occult is occult is occult.
As you had said, the symptoms and the exam findings are more.
Yeah, these. Exactly. Yeah, exactly. Yeah. The ones, microsurgery versus, that is the same thing. So the question is, what is microsurgery versus resection of the phylum terminale? So microsurgery is just the overarching term for when you take the microscope and to do your things under the microscope. That is microsurgery. And we microsurgically resect the phylum of the phylum terminale. And how common, yeah, so that was the good news. How common are CSF leaks post-surgically in EDS patients? It's the same thing. It's like 1.2%, I have to admit that at the beginning, of course, I could say I have ran into more CSF leaks, but then I learned my lesson, but then, I've been doing this now for 15 years and then I started to do this fat graft because, so it's with the fat graft, or diligent closure and paying attention to closure, you can trim it down to like a few percentages, even down to 1.2%. Can tether cord worsen? Yeah, okay. I think you had raised your hand many times.
So how many, so you talked about pre-tethering, briefly, and I was wondering, because I talked to other doctors, what is, too many tether cord surgeries for you? Like, where is your cutoff?
Yeah, so there's not always a black and white answer, but so the quick answer is I would say 3 or 4 times, because then I would worry about like arachnoiditis, and I know some people I probably had said 2 or 3 times. I know that. So, but you live and learn, certainly, and you might be upset, and I understand that, but again, you live and learn as a doctor. Now with the duroplasty, that I feel is a really valid thing to do. I have learned that this is even in some more complicated situation where the nerves are really clogged up, you can just release them, and then the duroplasty that gives that extra space is doing the rest of the job. So basically, the answer is, pending if the previous impression of the previous surgery was it's a fair thing to do. It wasn't like looking that everything is like super scarred, and you think you can go in again and tease the nerves off and then maybe offer the duroplasty. I think you can do it a few times, but I don't want to be, like giving a number, because everyone is unique. But I just want to, and I'm looking in some directions because, like you change your mind as you grow as a doctor, right? So I guess if I wouldn't change, then, then I'll be stuck like, like a dinosaur, I would say.
The phylum and rising like the smaller muscles in the spine afterwards.
Yeah, so there's a question of, is there a correlation between phylloresection and destabilizing? You mean like the smaller muscles? Yeah. So for now, I would say should stabilize them and not destabilize them. But the same thing, like for now we don't know because it could be, like that from all the adjustment that's going on, and it could be, So look, even though we all understand how bad the phylum can be, I also gave you some evidence the phylum has some functionality, right? So here it's. I hope it's not going to end up being a catch-22, So, but I'm saying, I think we still could do good things with taking the phylum out. I hope you would all support that. But it might be, that the functionality thing of the phylum is still somehow relevant. There's no way to measure it now. You just can assume that it might even control the paraspinous muscles. And then if you snip it, you might get less pain or maybe like improved bladder function, improved leg function, but you might be having a little trouble with your paraspinous muscles and you might feel more stable than before. I would also hope that it is a temporary thing, but might not. So that's why we're also trying to do that study that I showed you that in our gate lab, to see what happens. Okay, it's for many reasons. It's to prove that we're doing something, to hopefully prove that we're doing something good, but also to see, is it not always good?
Is there
Yeah, we're kind of on hold a little bit, so I was a little bit nervous to present this, but I also wanted to present to you that we're doing this. But this is, there are so many factors involved. So once we are a little more up and running, because May and Amanda will chop my head off if I now advertise it like to, so we're doing it. Because this is, so my opinion, this is what I wanted to do for 5 years. And we need a little bit more evidence because I think this is very important because I think it can explain a lot of what's going on in the body. And also for kids, we don't even know how to do consultations on kids now because parents always ask, well, my kid is not that symptomatic. Are you now going to do it prophylactically? Do you think you're going to do any good for my kids? Snipping the phylum. I said, well, and then they might still have some, but I said, but if your kid is getting worse, we're not going to let your kid. So it will help a lot of like mechanistic understanding in the body. So I might answer you, I might answer your question positive with a positive or negative answer, but it's not a study that we're going to have answers soon. So unfortunately, it's if we say high risk study, means like a lot of things are involved in getting that. It's not just the research team, but we're doing it. Oh, okay. Can tether cord surgery worsen spinal instability without retethering? I guess I just answered more or less this question, right? Why can like CCF? That is CCF is craniocervical. Oh, fusion. Okay. Yeah, so worsen tether cord. Yeah, well, that is the thing where that is a biodynamic problem. And then not only craniocervical fusion can worsen tether cord, any fusion, like anterior discectomy and fusion or thoracic fusion, you change the dynamics of the spine. You fuse the spine and the entire spine is moving differently. So that changes the spring mass damper thing. That my husband pioneered. You change the spine, so then you change the anchoring mechanism. So you change the entire spring system. So that has certainly effect on the mass, and on the damping system. So if you change the skeleton by a fusion, the entire anchoring is changed, and that affects the phylum, and that might tick off the phylum and cause tether cord. Why do you think pain bladder issues increase at 12 months versus outcome with 3 months? Is there anything to do proactively? That is a very good question. Do you track who completes physical therapy with 3 months outcomes? Oh yeah. So two answers. So basically, the question is why why does the bladder becomes worse after 12 months versus 3 months? And then if I track physical therapy outcomes. The first answer is it is probably due to the fact that so pain, I already gave you an explanation why it gets worse after 12 months because pain is so complex, right? But the bladder is probably, we see that in kids and in adults. So the biggest stress and strain still is on the colons from that phylum, and probably there's more damage than in the rest of the spinal cord. So you might do the surgery, snip the phylum, and the anchoring gets better. The nerves are more relaxed. There is more blood flow, but then the nerves recover, but they don't recover permanently. They then go back to their old mode. Some nerves might not be able to recuperate. So then there are still nerves that are dying off and nerves that recover, and then you have a happy median. I think it's because it's a chronic damage that has occurred, and so you have a short-term, a short-lived outcome, but not a long-term outcome. But it's usually still better than it was before the surgery. And then usually we ask is there anything to do? You have to get the urologist to co-manage the leftover bladder the problems. That's why it's actually sometimes good to have a urologist as a friend to begin with, to help out. And then a physical therapy outcome. Yes, we are now working together. I don't know whether she wants to be named, but there is a physical therapist, I think, down in Washington, and she actually works with Leslie Russell. I'm sure you know Leslie Russell, right? And she recommended her another research study that I didn't mention. You guys are so busy. We are now, are starting soon. And so we developed a new kind of questionnaire that incorporates physical therapy elements, right? That we're going to do before and after surgery, right?
For patients before they come to a neurosurgeon for recovery coordination.
Right.
Like a pre-evaluation assessing.
And then we'll also use it as a follow-up and see, so basically we will incorporate physical therapy driven outcome assessment as well. Yeah. Does it one more? Yeah, person. Yeah. Hey.
MRI showed the nerve bundle ends around T11. Could that still be tested for even if it's that far?
Yes, yeah. It doesn't matter where your cord ends. And T11 is on the high end, but yeah. Oh, yeah.
Does the type surgery have any effect on Chiari malformation symptoms or does it change anything after?
Yeah, it does.
Good way, bad way, or?
Yeah, well, same thing like for the CCI or so the all this concept of detethering the spinal cord and helping the craniocervical junction that again comes from the pediatric world. There are a good number of publications out there where the concept of actually cutting the phylum instead of doing the Chiari decompression in the pediatric population should be done because then you reduce the traction. And so now we translated it to the adults. And adults, I see too that if they have like a Chiari and we do the phylum resection, then the headache symptoms can improve. It's not that the Chiari would ever go away. You still have your tonsils down. It's just like due to the better motion, and anchoring of the natural anchoring of the spinal cord that also helps the stress of the nerves in the lower brainstem and probably even the spinal fluid circulation. Let's go back to the spring mass damper. If you fix the spring, the anchoring, you increase the damper system as well. The damper system is the spinal fluid system, so you might improve the spinal fluid circulation as well. So that might help the spinal fluid circulation at the base of the skull. But the same thing, like with the CCI, I also have patients that then say, Dr. Klinge, like my body from the waist down is awesome, but that's not any better. So then we also have to do the Chiari surgery if the person wants to proceed with that, of course.
If you have a CSF leak after an LP, is there a bigger chance of having a leak with the tethered cord surgery, or is that not related?
No, I don't think that is a leak is more like a connective tissue order problem, like just predispose you for a higher leak. One, yeah.
Yeah, so
Yeah.
people online can't hear when someone asks.
Oh, yeah, sorry. Yeah, there was, okay, yeah, I will go from.
Leak after lumbar puncture.
Yeah.
Increases the likelihood.
Yeah, so yeah, the leak after lumbar puncture increases, the likelihood of tethering, right?
Well, I was thinking, are they more likely to get CS from?
Oh, from the lumbar tethering. So the question was, are you more likely to have a CSF leak if you have a tethered spinal cord? I don't think there's a connection, and I don't see that. It's more like if you have a connective tissue problem and your dura is thin, then you are more likely to have a CSF leak. When do you think the new study will be released? I guess it's the EMG study. Hold tight. Fantastic.
There's more accolades, but the question is, how can we get more neurologists to be more aware of tethered cord, especially in adults? So many of the patients have to research, self-diagnose, and then find you or another specialist. Most neurologists don't even know to refer us to tethered cord specialists.
Yeah, so that's why, look, of course, I mean, we try to reach out and talk and educate others. I firmly believe in publications. That's why we made it open access. I mean, of course, you can do LinkedIn and whatever, social media, reach out. But I think you still, awareness is through publications, I would say, so, and then maybe you can do a better job like posting the publications everywhere. But then they also have to read it, right? People have to get interest. And nothing is better than in person. I guess seminars and spreading the word is important. But yes, I think I have to say there is more acknowledgement. I mean, even in the neurosurgery community, and I guess part of it is due to the publications that we did out of our center is helping, people to acknowledge this. So we're getting there. Not a satisfying answer, but that's what I have. Oh yeah, I mean certainly, like as I said, urology. So for all the symptoms, and I should have said that. Of course, a management of bladder symptoms with the urologist is very reasonable. If your question is, the question was if bladder symptoms can get better without surgery. Of course they can. That was your question, right? Oh. Mm-hmm. Oh, that's what you're saying. No, not necessarily. So I see you were saying, well, if my symptoms get better with physical therapy, then I cannot have teleport, right? Kind of thing. That's not quite true. It is true that, symptom management, physical therapy, pelvic floor therapy can improve, but you still have teleport. It is because, even though it's a bad phylum, like it still has ways, the body can still adjust, the physical therapist can change alignments, can strengthen your muscle, and that can have effect of your, posture, your spinal biodynamics, and you can actually improve the spring mass damper system, even, so of course, but usually, like you have to be aware that you can then have a relapse again, and it might not last long. But it is possible. That I don't know. No, I actually I don't check it, to be honest, because that would be like, it's a cranial nerve thing where you would say that is more like for Chiari, but of course you can say Chiari is associated with the cord, but I haven't looked at it. I probably should.
I have donated my body for medical school. I really want to donate it to the in the future be helpful to you?
Um,
I know that sounds silly, but.
but your body is helpful for me now, how you are alive. Okay, I love you. Okay, and I wish for many, many years, not. You just told me you have to get an upright MRI, so don't disappear on me, okay? Yeah, absolutely, like, I just don't know how long I'm gonna be around, but I guess, it's absolutely, yes, because, the tissues, and I thought this histology will help a lot, and, you asked me a question on a cadaver, we can even do like mechanistic studies and look at, more advanced tissues. We could look for like genetic markers that had not been able to, be diagnosed in life personally. So yes, absolutely. Absolutely.
Joined a little early.
Still, you're gonna be in trouble tonight.
And I just wanted to ask you, for it, like, is there more evidence that doing the gel probably not have to be added after post-infection? That there's infection, mast cell infection, like if someone, the progression is this one still good not under control, like lying and long COVID, see that patient who has surgery with gel, like, do they have harder time having better outcomes during mast cell, long COVID and lying? Mast cell is also very common with long COVID and lying patients.
Yeah, that's, so the question is, could it be that the outcome is not as good or more effective in people with long COVID or Lyme, whether the mast cells are part of it or not? Yes, we have to believe so. I mean, I also see that. I mean, that wouldn't be, so for now, I don't make that a criteria to not offer surgery, I have to say, because I still believe it's a neurological problem, and, like, the surgery is still beneficial. But I do see that people with, like with chronic fatigue based in the realm of long COVID have a harder time to recover. The problem is, and that's what I also start to discuss with patients now, that if the body is very deconditioned from these conditions, it's harder to recover, of course. In tether cord, you usually want to use your body right away, go to the physical therapist, and become active. And it is a problem, yes. Oh, yeah. Question is, should we get the neuroinflammation under control before doing the surgery to have better outcome? Yeah, I mean, to be honest with you, probably it's just hard to do this, right? Yet you have a progressive neurological condition that you wanted to help, and how reliably or how good can we get these conditions under control? Because even here we don't have a final definitive like treatment regimen, so as a very personal thought, yes, that I believe that would be important. Just the management of it is still not, and we don't have that multidisciplinary team that is willing to kind of do this.
Craniosacral therapy, not advised, or proceed slowly, or how do you feel about it?
Craniosacral therapy, or?
Yeah.
You mean whether this is a good thing to?
Yeah, with someone technically.
Yeah, I think it might. Yeah, so
not something you say don't do.
Oh, no, it's the opposite. Okay. Because I believe that craniosacral therapy, as it helps the ligaments, and relaxes the ligaments, might help, like the anchoring, So look, again, filum terminale is a ligament that's connected to the dura, and the dura is connected to other ligaments. And it's not only at the base of the skull, also at the bottom, we have this, like connection. So our spinal cord and the phylum, they're not just like, sitting in their, like box or in their class, or they are connected to the peripheral ligaments. So that's how I think that the craniosacral therapy helps. And in people that are not clear, or if we find we're not going to do surgery or for whatever reason, but there might be an element of center cord, then this is a valid therapy, absolutely. Mhm.
This year.
Yeah,
What she touched.
yeah, absolutely. No, that's a good thing to do.
All right, we are at time for our meeting. I'm so sorry if we weren't able to get to all of the questions. I want to thank Dr. Klinge again for coming out, and especially her research assistants as well for helping us and getting all of the. We do have the Collis Family Gallery right behind this auditorium reserved. There are some snacks in there if you'd like to mingle and talk around. If you are you planning on staying here? Okay. That's probably a good thing for Dr. Klinge, because there's a lot of us and one of her. So
Sorry, I have to commitment.
of course, thank you so much for your time today. I have something for you before you go. But thank you again to everyone. I'm going to shut down the webinar for now. And thanks so much for coming. Good to see you.